if Seth's still on, I'd like to turn this over to Seth. And Seth has been working with the AUA in terms of creating guidelines on how to handle shortages and maximize treatment options in situations where there is a shortage. Dr. Lerner, are you
here?
Okay.
Yeah, can you hear me?
Yes, we can hear you.
Okay. Yeah. Okay. Thanks for that excellent introduction, Rob. Can I get the next slide, please? Okay. So this is a real challenge, and there's a fair amount of variability from one site to another, from perhaps different regions of the country, and say, for instance, in our case at Baylor, how much we had on hand at the time that this shortage really began in earnest. So some sites, some doctors may actually have enough BCG at the moment, and even with allocations and limited supply moving forward, are able to stay ahead of things. And then the other thing that you'll hear a little bit later is there's an opportunity for clinical trials that provide BCG or an alternative to BCG, and an individual patient's eligibility will depend upon the grade of their cancer, whether it's a first occurrence or a recurrent cancer, if they've had BCG before or not. But it's in the midst of this BCG shortage, clinical trials really provide an opportunity for alternative treatment strategies or other approaches to immunotherapy, which is how BCG works. Next slide, please.
Dr. Lerner, this is Stephanie. And, we were just trying to throw a few comments in here too before we get into the AUA guidelines. We want to do our best to help ensure that BCG is available, and Beacon is speaking out. We have some information that is available if you want to contact your elected representative to let them know how you're being impacted by this. And again, you can go to the website and sign up to receive advocacy alerts. So now let's get into the specifics of what the AUA guidelines have been modified so that we can kind of accommodate what's happening during the shortage.
So next slide, please.
Yep.
Yeah, so at a meeting where pretty much all of the stakeholders, including BCAN, were present at the table. This was in February. We had with us representatives from Merck, the American Urological Association, the Society of Urologic Oncology, Large Urology Group Practice Association, and NCCN Guidelines, in addition to Rick Bangs, Dr. Svatek, and myself. We, subsequent to that, issued a joint statement which reflects what I'm about to go over right now. My personal sense of this is that if urologists consistently will follow these guidelines, then I think that this shortage will be hopefully short-lived, and the supply will essentially meet the demand by having modified and decreased the demand, as I'm going to outline now. So there's a group of patients who are actually probably the most common patients that we see who have what we refer to as low-risk disease. So this would be a solitary non-invasive cancer that's less than 3 centimeters, that's low grade, and the standard of care for treatment is to have the tumor removed through a cystoscope. That's generally a procedure that's done in the operating room, and then oftentimes we'll give a single dose of chemotherapy, not BCG, right after the procedure, and that's really all that they need. So there's the guidelines don't support using BCG in this setting, and I think it's safe to say that most urologists probably don't use it in this setting. The next thing is that the next group of patients is called intermediate risk disease. So they still have non-invasive low-grade disease, but now they've recurred. In other words, this is their second or more tumor events, and they may have multiple tumors in the bladder at the same time. So there is a standard of care for those patients to be treated with either chemotherapy instilled into the bladder. We use a variety of different drugs. They're listed here on the slides instead of BCG, but BCG is also considered a standard of care, and what we've recommended because of this shortage that BCG no longer be used in this setting. Patients will not sacrifice, in my opinion, any reduction in efficacy because we have a lot of experience with these chemotherapy drugs, and particularly mitomycin. And in this particular disease state of intermediate risk disease, they're very effective. And so I think that if urologists curtail the use of BCG for this group of patients, then that'll go a long way towards alleviating the demand. And then BCG should be held as a backup treatment in case chemotherapy doesn't work in this setting. And we now also can use two different chemotherapy agents in the same treatment session. So many people are using a combination, for instance, of gemcitabine and docetaxel. Usually we're using that for our higher risk patients, but it's also an option for patients with intermediate risk disease that's recurred after single agent chemotherapy. So BCG is very effective, and we just want to hold it for those patients who have failed conventional intravesical therapy. Next slide, please. So the challenge is that for patients who present with high risk disease, so that's any patient with a high grade cancer, especially one, T1 is an early invasive cancer, but not into the muscle. Carcinoma in situ is a high grade cancer that's just in the lining of the bladder. Those patients should be prioritized for using full strength BCG because that clearly is the standard of care. And if BCG is not available, these patients and other high-risk patients can be given a reduced dose of BCG. And many of us will combine a reduced dose of BCG with another immunotherapy drug called interferon. So the combination of BCG and interferon may be good for patients who, say, recur with a high-grade cancer after induction or 6 weeks of BCG, or after a period of time where they've been treated with BCG and then recur with a new tumor. So the benefit there is that you can reduce the dose of BCG, and therefore what many of us do is we can take a vial of BCG and split it between 2 or 3 patients in order to maximize the benefit. And then if the patient does respond and gets induction or the 6 weeks of BCG, and instead of using full dose BCG for maintenance, then we can use a reduced dose and treat up to at least up to 1 year. And then if BCG really is tight, if the supply is really tight, then we have to prioritize patients who need to be treated with that initial 6-week course of BCG. That's what we call induction. Next slide. Stephanie, can you go to the next slide? I think we missed one. Can you go back? Yeah, okay. So there's some other situations where we have to be a bit creative, and there are often situations where either BCG has been tried, it's no longer effective, where the terminology for those patients is BCG unresponsive to disease. And that's typically patients who've recurred with a high-grade cancer after receiving induction plus 1 round of maintenance. BCG is not appropriate therapy after that. And we've listed in the slide here a number of different options. I've mentioned already the combination of gemcitabine and docetaxel. We've also used gemcitabine and mitomycin, and we can use that for induction and maintenance in the patient who no longer is felt to be a good candidate for BCG. And then, to be honest, there's a group of patients who really, where BCG is no longer effective, and we're starting to encounter a risk of progression to a worse cancer or muscle invasive cancer. And there's clear indications for some of those patients that removing the bladder or radical cystectomy, if they're considered to be well enough to undergo the operation, that can be curative. And that really doesn't change. We'd like to think that that doesn't change in this BCG shortage. I mean, it'd be really, it wouldn't be ideal if a patient, simply because of a shortage of BCG, their only alternative is to remove their bladder. Fortunately, we have a lot of experience with these other chemotherapy drugs, and I think most of us are comfortable, giving that a try before moving on to radical surgery. I think the next slide. Okay, so should I continue, or is Rick, are you going
to? We just wanted to offer up some trials that would be appropriate for patients to consider in the BCG naive stage. In other words, they have not had BCG. So these are 3 that are currently available and can be seen on the Beacon dashboard or on clinicaltrials.gov. Trials do change over time, so these are 3 that are relevant today, but there may be others in the future.
Okay.
Yeah, I think, Rick, since we've got the principal investigator of the PRIME trial, Rob, do you want to give it'd be worthwhile if I may, just to give an update on the BCG supply for that trial?
Yeah, so that's the first one listed there is PRIME S1602, which is available to many sites in many states. And the trial involves randomization of patients to either Tice BCG or Tokyo strain. And there's a third arm that can get Tokyo strain with an extra vaccine given intradermal. And there's more details that are available there at clinicaltrials.gov or on the Beacon site. But we have been in contact with Merck, the supplier of Tice, who has graciously been able to assure the provision of Tice BCG for patients on trial for both that first trial as well as their keynote trial. So that, at least for patients on trial, they'll have a steady supply for the induction and maintenance course. I do want to point out that these is not comprehensive, does not include all potential trials out there that are available. There may be trials that are unique to your particular site that may be available that were just not seen in our review. So you can talk to your local urologist about what trials that they may have available there that may not be listed here.
So just so everyone knows, other clinical trials relating to bladder cancer specifically are available on our clinical trials dashboard. If you visit clinicaltrials.bcan.org, you can get a more complete list of trials. It allows you to enter the diagnosis that you might have, and then you can select the state that you live in or where you could potentially engage in a clinical trial. and you're able to save those trials. You can establish an account, you can save those trials, and you could email them directly to your healthcare providers if you were interested in getting their opinion on whether a clinical trial might be the right thing for you. So please do visit us. We only have bladder cancer clinical trials on this website, but it's the same trials that are listed on clinicaltrials.gov. We have a special feed that goes directly to us with all the open trials, the trials that are recruiting patients currently. So Rick, you want to talk a little bit about the patient perspective?
Sure. All right, so let me start by saying this is BCG is very early immunotherapy. We don't normally think of bladder cancer, at least historically, we did not think of bladder cancer as being on the leading edge or the cutting edge. But in point of fact, this is before immunotherapy became popular in the last few years. And an old treatment is not necessarily a bad treatment, all right? And so that's why we do clinical trials, is we try to compare a new treatment alternative with an existing treatment alternative. So something that's already available is not necessarily worse than something that's new. The second point here is that BCG is effective for many patients, and it has acceptable side effects. But it is not effective for everyone, and that leaves open the possibility for better coverage and more effectiveness, and some of the clinical trials that we have talked about tonight. There's some inconsistency in the administration of maintenance BCG. There are some guidelines that are published, but there may be some inconsistency in how people interpret the use of maintenance BCG. And the side effects are generally acceptable, but there are some patients who would have some difficulty. All right, even today, almost 30 years later, the mechanism of action of BCG is not well understood. So one of the things that's being done with the trial that Dr. Svatek talked about, the S1602 trial, is to better understand how BCG is actually working so that we can better understand how to treat bladder cancer. It is relatively low cost, and that is always an important factor for patients, especially compared with some of the new alternatives that are being studied. All right, and so things like immunotherapies tend to have fairly significant cost, and BCG is on the relative scale of things a low-cost treatment. And these new alternative treatments and low profitability are likely going to hinder the building of additional capacity by the BCG manufacturers. The next point is that it's a biologic. You heard that it grows on potatoes, and so it's challenging to consistently produce. You don't get 100% every time, and as I understand it, you don't know until the end of the growth cycle, if you will, that the batch is not going to be good. So that makes it additionally challenging to produce. This is our third shortage in about 7 years. So I can tell you from looking at the Beacon Inspire site that survivors are angry, frustrated, and incredulous that we are where we are. It's, I think, relatively unclear to us why we have a shortage, although we do know that there is some reported increase in demand, and we're looking for some accountability for supply. Patients, I think, are confused about their treatment plan and unwilling to accept lesser alternatives, and so we kind of walk through what those alternatives are, and Dr. Lerner gave you, kind of an assessment of the alternatives and how successful they might be relative to BCG. But I think as patients, we're a little bit concerned on that. Many of you are not complacent and are willing to work on fixing the short and long-term problem, and there's been some discussion tonight about how to do that, and we'll have a little more discussion in the next few minutes on that. And the maintenance guidelines proposed during the shortage are concerning. I understand that there may be some billing challenges with partial doses, although I understood that those were being addressed, and hopefully we've reached some conclusion on that. And last but not least, there are at least three clinical trials that patients may want to consider. There may be additional trials coming up, so by all means, talk to your doctor and find out what makes sense for your situation. And these trials are testing alternatives alone or in combination with BCG. And to my knowledge, there are no trials for substituting an alternative treatment after you've started BCG. So I think in a perfect world we would have that, but the challenge is that alternative treatments have to prove themselves in untreated patients first, and so we don't have a trial available, to my knowledge, that allows you to have started BCG and then switch to certainly another strain or an alternative treatment. But by all means, talk to your doctor about that possibility. And then clinical trials are not accessible to everyone due to the distance from the location where you would get the clinical trial. So work with your doctor, find out what makes sense for you in terms of where you live or where you could go for treatment, whether it's a member of your family or a friend that you could stay with during treatment. But they may be a little more accessible if you open up to those possibilities, but they are not universally available. You cannot go to just any location and get a clinical trial. Next slide.
So we really wanted to just give you some other suggestions too about how you can advocate for more options. This is clearly a big concern. This is a global problem. We were notified by Merck at the beginning of the year that they anticipated this shortage and they had ramped up production, and yet they're still unable to meet the demand for the BCG. And this is a global concern. And so that was one of the questions that has already come in. So definitely consider a BCG alternative clinical trial is part of your treatment. Talk to your doctor about that. And if you know other bladder cancer patients, you could also pass that along to them if they weren't able to be on this call. Please watch beacon.org for more communications and more ideas. We have the BCG shortage at the top of our website, and we're trying very hard to keep that as updated as we can. And absolutely help us to advocate for more funding in the research space if we can get more of these drugs through the clinical trials and into the approval process. And we will definitely be helping to spearhead that however we can as an organization through the FDA approval process. We will definitely do that, but definitely looking at more options for research in this area to find alternative treatments or approval of different strains is definitely going to be something that we hope will help to shorten this current shortage.